Okay, thanks. Hello, I'm Chris Pugh. I'm Professor of Renal Medicine in Oxford, and I direct something called the Oxford University Clinical Academic Graduate School. And I'm delighted to be able to give you a few thoughts on how you might incorporate doing a DPhil, the Oxford slang for PhD, into your postgraduate clinical training. So you'll all be familiar with the standard clinical progression from a medical degree through foundation program, core training, specialist registrar training towards a consultant or GP role. And those of you interested in academic progression will know the route from a degree to a doctorate, perhaps through an intermediate and senior fellowship, to a senior lectureship or readership or professorship. But one of the things that has been developed over the last decade or so is the integrated academic training pathway, which provides a number of links between these two previously distinct career paths in the forms of the academic foundation program, academic clinical fellowships, and clinical lectureships. So let me just tell you a little bit about each of those three steps, and then we'll talk about routes through this maze and give you some general advice. So the academic foundation program in Thames Valley has 24 places per year. These provide protected time for academic endeavours, and that is typically, but not always, a 4-month block of academic time in the second foundation year. The idea behind the academic foundation program was to allow people to get some generic research experience to decide whether they did or did not like this way of earning a living, and to give them some skills training. And we try to supplement that with some individual support. The NIHR academic clinical fellowships are a more substantial part of academic training, and probably more designed for people who are aiming for an academic clinical career rather than those that just want a taster. They're typically 3 years in duration, but 4 years for GPs, and they provide 25% of the time to be protected for academic training. And one of the specified aims from these clinical fellowships is that candidates should be hoping to apply for a doctoral fellowship, or if they've already got a doctorate, a postdoctoral fellowship at the end of their clinical fellowship. These have a personalized training program and access to master's level modules in research methodology. The final step in the integrated academic training pathway is a postdoctoral step, and that is the clinical lectureship. Here, time is protected for academic work 50% of the time, with 50% devoted to clinical training. They're only open to people who already hold a doctorate. They're up to 4 years in duration, and occasionally now people can apply to extend them beyond CCT. They're highly personalized, and the aim with a clinical lectureship is for people to transit from the supervised role of being a doctoral student towards independence. And I mention them at this stage because I think it's important to think about destinations as well as entry into doctoral training. So with regard to that integrated academic training pathway, there are a number of steps which can be either regarded as isolated or joined together. There's no correct route through this pathway. It provides many opportunities, and there is scope for plenty of opportunism. So just to explain what I mean about routes, I guess one way of taking advantage of every step on the integrated academic training pathway would be, after completing a medical degree with or without an intercalated degree, to move into the academic foundation program, to come out of academic foundation into a core training post, but then get an academic clinical fellowship, step off to do a doctorate, return to a specialist registrar post, step off to be a clinical lecturer, and perhaps end up with an academic post long term. But of course, many people won't want to go through every single step on that pathway, and some may, for example, have done an intercalated degree at university, have no particular further interest in academic work until they suddenly meet an interesting clinical problem as a specialist registrar. And at that stage, they may head off and do a doctorate without doing an academic clinical fellowship, and that may qualify them to become a clinical lecturer and again on into an academic career. Or indeed, they may choose not to move to an academic career, but to carry on in an NHS role. And NIHR is very keen to increase the number of people with research training in standard NHS roles, as well as to support the clinical academics of the future. So there are several opportunities within this integrated academic training program to step out of clinical training to do a doctorate. And I'm just going to talk briefly about the distinction between doing a doctorate from within one of the training programs, and then I'll go on to talk about the pros and cons of stepping out to do a doctorate in a gap between one of the steps in training. So what I mean by doing it within a program is to interrupt your foundation program to do a doctorate, to interrupt your core training or your higher specialty training to do a doctorate, rather than stepping off at the gap between these different phases of training. So the important thing is, if you're in a training program and want to do a doctorate, is you will need to apply for out of program permission, and in the form of OOP-R, out of program for research. To do this, it's really important to begin discussions early with your training program director. Don't surprise them asking them to fill in the form at the last minute, because they're trying to keep the whole specialty training program together, and also the service provision that comes with that training program. And they don't like gaps, because that alters clinical care, and it also puts a lot of pressure on your colleagues. So the absolute minimum period of notice for getting OOP-R is 3 months. But it's actually much preferred if the discussions start, perhaps even 12 months earlier, and certainly 6 months earlier if GMC approval is required for the time out of program to count towards your time for CCT. I would strongly advise anybody who is going OOP-R to retain their license to practice, to maintain their GMC registration, and to maintain an honorary NHS contract whilst on OOP-R, even if you're not seeing any patients. We can discuss the pros and cons of that at some point, but I would just give that advice because I've seen people being caught out by not doing it. One of the features of maintaining these contacts is that you can then continue to provide evidence of fitness to practice through your links to Health Education England, and that will help to maintain your revalidation dates. At the other end of a period of out of program for research, it's really important that you maintain contact with your training program director, explain to them your plans to return to practice, and actually that you and they negotiate a return to practice plan to allow you to regain any clinical skills that may have atrophied a bit during your time doing research. It's a small small print point that people doing a doctorate typically transfer from NHS employment to university employment. The position is improving all the time, but this transfer potentially involves potential changes in your rights to pay pension, parental leave, sick leave, and this sort of thing. And it's worth just being a little bit careful about that. There are all sorts of worthy documents now saying that these rights or employment benefits should be maintained when you transfer, but occasionally people get caught out by that. So if you're likely to be in a sensitive position in that regard, it's worth just double checking where you personally will stand. So the alternative to taking time out of program is that you can take time out between programs to do a doctorate, and that does not require permission through OOP-R. But it does cause some potential risks in your eligibility for subsequent employment. So if somebody chooses to take a break between medical school and foundation to do a doctorate, and that doctorate lasts more than 2 years, and they almost all do, you will need to meet eligibility criteria to enter the foundation program, akin to doing medical finals again, a 16-station 4-hour OSCE. So I'm not discouraging people from doing this if they wish to do so, but they should be aware of that penalty clause. If you choose to take a break between foundation and core specialty training, be aware again that you may well have to provide an alternative certificate for foundation competencies by the time you apply for core or specialty training places subsequently. The competencies you get from the current foundation program lapse after an interval, and this requirement is being brought back in. Those both sound like significant disadvantages for taking a break between programs. But one big advantage of it is that if you apply for UPAR, this is limited to 3 or 4 years across your entire program of training. And if you use all of that up for a doctorate early on in your training, it gives you precious little scope to have further academic time later on outside clinical lectureship roles where the academic time counts as being in program. One final point for those with a financial interest is that there is now an academic pay premium available for people who undertake a DPhil as part of their training. But there's quite a lot of small print around that, and essentially you're more likely to qualify for a pay premium if you take time out of program rather than between program and return to the same program of training. So if that interests you, and it is worth several £1000s per year for the remainder of your training, then you should just look at the small print and make sure whether you will or will not qualify for it, so that expectations are not falsely raised. So how do we support people undertaking a doctorate within their clinical training in Oxford? Well, we do this through the Oxford University Clinical Academic Graduate School. The website is there, and there's also a generic email address if you have particular queries that you would like to ask about. This is a partnership between the University of Oxford and Health Education England in the Thames Valley, and it is originally set up to oversee clinical academic training and the integrated academic training pathways specifically, but we now link in to people who are taking time out of program or between programs to do a doctorate. The reasons we have an academic school are we believe that it's helpful in attracting, training and retaining the very best clinical academics, and generally raising the profile of clinical academic careers. We spend a lot of time working with the university and Health Education England to try and ensure that the best infrastructure is available and inspiring the aspiration to excellence. We also act as an information resource for both trainers and trainees, hence advertising our website and our email address on the earlier slide. And of course, the underlying wish behind all of this academic endeavour is to improve patient outcomes. And I think this is important and something that we do achieve. So part of the balancing act that has to be done in clinical academic training is to balance the advantages of clinical training with those of research training. And there are some real contrasts here. In clinical training, I've tried to summarize some of the features, but there's a tendency to minimize risk, be certain over core competencies rather than excellence, to think about national recruitment, and to make sure that service commitments are covered. And you can read the other things on the slide there. And research contrasts with this because of the calculated risks that are involved in doing research. If we knew the answer, we wouldn't have to do it, so we have to take a gamble. It tends to involve a niche rather than something that can be recruited nationally. There's a complete uncertainty often about the direction of travel, which people have to get used to, compared with aiming at predefined core competencies. There is quite a lot more flexibility compared with the service commitments on the clinical training side. And whilst we don't want people to behave completely bizarrely, there is a bit more scope for mavericks and people who perhaps don't fit in to conventional pathways. The timescales are a bit flexible, the funding is a bit less certain, and the availability of long-term posts is a bit less secure. But what we're anxious to do is to help people balance these different aspects. Putting that another way, we see ourselves as contributing to the stability of this triangle. So those undertaking a clinical academic career pathway are partly under the influence of the University of Oxford, they're partly under the influence of the Health Education Thames Valley, and they're partly under the influence of NHS service providers. And all of those different organisations are working to slightly different agendas, and the trainee caught in the middle can be doing an interesting balancing act between the pressures that come from service delivery, from training, from governance, from research and education. And what we hope to do through the Clinical Academic Graduate School is to help that balance to be established into a place of serenity where good progress can be made. Putting that another way, we're adding an extra tier of support to the training structures available to academic trainees. So if we think of the normal Health Education England trainees, they have the support through the deanery of their specialty school, the head of school, the training program directors, and then within their individual hospital or GP practice, the educational and clinical supervisors. The academic trainees are exposed to all of those benefits, but in addition, from the academic school, they get support from academic training program directors, myself as head of school, and academic supervisors. And both types of trainee are also open to get support from the career development and professional support unit. So we see this as an integrated package in which we work closely with the deanery to make sure that academic trainees get the best possible support, but we act also as spokespeople for the academic trainees where tensions arise between their clinical and academic training requirements and aspirations. So the type of program we run includes some research training in the form of those master's level modules, which can be put together to get a postgraduate certificate or diploma in health research. We run a regular mini conference called the Academic Medical Forum, and we provide academic opportunities seminars. And we also link in to the university's Medical Sciences Division graduate skills training. We provide career support in the form of some research funding bursaries, support for career development, helping to cover issues that are not equal between the genders, for example, and providing regular mentorship. I think importantly, we like to provide a sense of community and bring together academic trainees, whatever their level, whatever their specialty, whatever their research endeavor, so that they can build a sort of community ethos and esprit de corps. And through that community, we also provide a one-stop shop for information for both trainees and supervisors. And part of our role is obviously one of communication. I guess that's one of the reasons why I'm here talking to you at the moment. But we do that partly through talks such as this, and partly through an electronic infrastructure, which is maintained by a very dedicated, relatively small admin team. So this is an indication of who we are at the moment. I just from your point of view would focus on the academic training program directors. So we have Paul Johnson, who's a pediatric surgeon, but looks after some of the surgical trainees with an oncological interest. Dominic Furness has joined him as another surgical academic training program director in that role. And Kilty is a clinical oncologist. So again, she has expertise in areas of research that may be close to your heart. The other people here are an infectious diseases doctor, a neurologist, an obstetrician and gynecologist, and I myself am a nephrologist. And from the academic foundation perspective, we have a psychiatrist, a diabetologist, and a nephrologist with an interest in clinical trials. But the important thing is that it's an integrated system linking Health Education Thames Valley and the University of Oxford. Just to give you an idea, we typically have about 150 people on the integrated academic training program at any stage, linked to about 200 clinically qualified DPhil students in Oxford. We're working on the male to female ratios, but they're better than in some other parts of medicine. Here I've highlighted the enormous spread of specialties in which we support academic endeavours, and I've just put in red the ones that have an oncological link to give you a sense that we're working quite hard to support colleagues researching in oncology areas. And overall, many of our trainees go on to further academic endeavour. The percentage goes up the more senior they are, in keeping with the idea that the foundation programme is a bit of a taster. The academic clinical fellowship hopefully will lead to a DPhil, but people can then choose whether academia, more serious academia, is or is not for them. Whereas by the time people become clinical lecturers, we're hoping that the majority of them will go on to a full-time clinical academic career. And that certainly has been the case in oncology. The oncology percentages for clinical lecturers are, I think, still 100%, certainly pretty close to that in terms of progression to an academic career. So just to wrap up, our aims through the Clinical Academic Graduate School are to recruit the best academic clinical trainees with the greatest potential, to foster an environment in which they can flourish, and to help them to progress through the current stage in their career towards that next stage. And I would welcome any of you to apply for a DPhil here. And if you do so, I look forward to helping support you achieve your best potential. Thank you very much.